A quick note before today's episode. While I'm a professor of nursing at the University of Minnesota, this podcast, Midlife Unmasked, is a personal project and separate from my professional responsibilities at the university. This podcast is intended for informational and educational purposes only and should not be considered professional medical advice. Please consult your own healthcare provider before making any decisions related to your health and wellness. In keeping with my role as a nurse researcher and educator, I'm here to bring evidence-based information to improve overall health and well-being. It is my goal to be a trusted source of information and to build this community where we can all learn, grow, and share together. With that said, let's jump into today's conversation. Hey Midlifers, welcome to the Midlife Unmasked podcast. I'm your host, Robin Austin, a nurse researcher and educator, and your guide to navigating everything from healthy aging and wellness to big stuff like caring for aging parents, mastering work-life balance, and discovering your next great adventure. So are you ready? Let's do this. Hey Midlifers, welcome to our episode today. Today, we're uncovering the science of women's sexual health, a conversation with patient advocate Aimee Osgood. Aimee is a vulvovaginal sexual health patient advocate, educator, and researcher, as well as a proud member of the International Society for the Study of Women's Sexual Health. She's passionate about making complex science approachable and meaningful, with a special focus on the effects of women's sexual and vulvovaginal health. Aimee dives into the medical research to uncover the why and how behind issues such as infections, pain, and changes in libido, highlighting both what is currently known and what is being studied. Her mission is to bridge the science and lived experience to improve the diagnosis, treatment, and overall well-being for women. Let's go ahead and welcome Aimee Osgood. Before we begin, I want to offer a bit of context. This conversation was recorded before I had the language to what now connects so many of these episodes, what I call the missing decade, the overlooked years of midlife when women experience profound health, identity, and life shifts without adequate explanation or support. As you listen, you'll hear exactly why these topics belong here. You'll notice themes of dismissal, silence, and self-doubt surface again and again, not because women are failing, but because the systems around them never fully named what was happening. I'm sharing this episode now because conversations like this made the pattern impossible to ignore. They revealed the truth gaps midlife women are navigating, often when being told everything is normal. This is one of these conversations that helped me to name the problem more clearly. So let's jump right in. Hey Midlifers, welcome to our podcast today. I am super thrilled for our guest that we have, Aimee Osgood. She is here to talk about all things, again, midlife health. And we're going to hear from her and her background and how she got started and where she is today. So welcome, Aimee. Thank you for being here. Can you give us a synopsis of what led you to what you're doing today and really what inspired you to become a patient advocate?
Yeah. Thanks for having me, Robin. So it all started, I was pretty young. I was probably before 20 years old, having a lot of women's health, sexual health, like vulvovaginal health, like issues. And I wasn't getting any traction. To be fair, there wasn't a whole lot of research in these areas. There's still not a ton now, but there wasn't a whole lot even back in like 2000. It was kind of budding. I would try to see doctors. I would get terrible advice. I would have a drink, read a romance novel. There's not much that we can do. I would get told I was too young for things. I would flat out refuse to test me for things, but I knew that there was something wrong. But when there's not a lot to be done or for your doctors to have answers, you try your best. And I would see a doctor maybe, I don't know, every 3-4 years, try to get help. It wouldn't get anywhere. And I went through this for about 10, 12 years. And I finally found a sex med specialist. This was still, research was just starting to take off. And so she was able to help me. She was great. She was able to start me on the journey of getting some traction and getting my health under control. Because things were still very, very early in the beginning, I started taking to reading everything that I could. If I found a book, if I found an article online, and I stumbled across PubMed. And due to my job at the university, I have full access to it. And so I was able to get behind all the paywalls and be able to search a lot more and have better resources. But I started reading the PubMed published research. And I found that it's like my jam. So I kind of I read that stuff for fun. It's kind of one of my goofy quirks. But I found that I was devouring all of this information and it would lead me down these rabbit holes. And so I would try to read about one thing and it would lead me all these down these little rabbit hole trails. And I was just consuming a massive amount of information, partly because I liked it. And I was hoping at the very least that I could educate myself, give myself tools to then help my doctor help me. It wasn't so much like I wanted to try to treat myself, but if they were lacking in answers, maybe two heads were better than one. As the years progressed, this is probably a few years I was doing this, I would continue to see my doctor. We would continue to learn about new things. We would make more progress on my health conditions. And then I would say that this was about 2017. Things were going pretty good. We were making a lot of progress. I wasn't on social media very much, but I heard about Reddit, and there's things called subreddits, which are groups. It's like a group within the platform. And I found one that was called Healthy Hoo Ha. And I started trying to help other women and users of that subreddit get their questions answered and get them help and help them see the clinicians that could help them gain traction in their health conditions. But I noticed that I was spending hours a day commenting to people. I was repeating myself a lot because a lot of these things a lot of the posts on there were very similar because it was things that women weren't getting answers to. So it was just a lot of repetition, a lot of hours in the day. And I thought to myself, there's got to be a way that I can reach a wider audience who then can take, it might not be as individualized of an answer to them, but they could take the information that I've gathered and take some time to consume it. So in collaboration with the Healthy Hoo Ha subreddit, I said, hey guys, I want to start this website. I want to call it healthyhooha.com. I think the branding is very familiar with people. And so I started the website, healthyhooha.com, and I publish on there. I suppose for lack of a better term, I publish my articles. And so what I've done is I've taken all of the information that I've consumed from the research, and I've been able to take that science speak and flip it into a language that patients and regular people can understand. My resources and articles are a little bit longer than your general posting on social media, but it provides more of the in-depth information that is answering the questions that aren't getting answered elsewhere. So I started that, and then I started looking for other people like me. There wasn't a whole lot of other patient advocates that I could find, but I did find an amazing organization called ISWISH, which is the International Society for the Study of Women's Sexual Health. And they were one of the first organizations to accept patient advocates as members. So I have been a member of that organization for the last few years. I have given talks with them, and I have presented abstracts and papers with them. And it's given me the opportunity to collaborate with other people in the sexual medicine space. And so I've got a couple of papers we've been working on getting published. I am trying to I have all kinds of things in the works. I have things like sex ed modules, but I've gotten to this point now where I'm helping women online still. And I've got my things that I publish on my website, and I've got collaboratory projects with other sex med specialists. And it was all so that if I could stop one other woman from going through what I went through, it made it all worth it. And that's kind of where I am today.
I love the story. Thank you so much for sharing the journey. I love it on so many levels, I think. And specifically, one, that you had a provider that was open to you bringing in other articles and other research. And I've heard from other friends and other individuals or patients is that I've brought in this article and it was either poo-pooed, it was dismissed, or what do you think, bringing in research to me kind of. And so that's so unfortunate, but thankfully you had someone that was open to it, and really a very collaboratory process. So that's amazing. And how lucky to have that. Mm-hmm.
Yeah. I try to counsel patients or women online. It's to maybe bring it in, but ask the doctor. If you feel like the doctor might be hesitant, just ask them what they think and tell them that I'm just trying to get help. I've been to many doctors. It's been years. Can this be related? Is it not related? Can we try to figure out? So it's like, you kind of have to have this. If you feel like your doctor is being hesitant, finding a way to disarm that defensiveness.
Yeah, that's a great way to put it. I think it's going from the position of partnership and just we're all trying to find answers and let's work together. I think that that's super, super helpful. The other piece you had mentioned, and we'll go on to our other questions, but your organization, the ISWISH, allowed patient advocates to join, which isn't always normal. And I think that's the other component, is that if you're really, as a patient and an advocate, looking for something, finding organizations that allow patients to come in, I mean, that's where the conversation happens. And that's where I think change happens. So finding that's amazing that you're able to do it. And you did, you joined. That's great.
Yeah, thanks. Thanks. There are a couple other advocates as members on the organization. We are great friends. I think we're providing them some very valuable perspective. It's been awesome. They have been so wonderful.
Yeah, no, that's great. I think from a clinician perspective, from a researcher perspective, having those that you're trying to help part of the solution. And it's all about the co-creation and the co-design of solutions going forward. So I hope that more people live up to that model as well. So I love that. So another question that I have is, we look at it, is many women struggle with issues like infections, pain, changes in libido, but may not seek care. So what do you think of, or what would you say to some of these, for these conditions that often get overlooked or misunderstood?
I have some opinions on why women's health issues aren't studied and researched, but on a more positive outlook for that, I think just in general, the lack of research has had a systemic and detrimental effect. So just when there's a lack of data, many institutions and clinicians will say that something can't be happening, like your experience isn't valid. It's like the data doesn't support what you're saying. A great example is the sexual side effects from SSRIs. For decades, patients were screaming that they were having sexual side effects, and the medical community kept denying them their experience. And it's finally coming out that this is, something that's side effect of SSRIs for many people. And it was a matter of that the research just hadn't collected that data. So it's not going to be data there because you didn't collect it. Women's health issues, I think, are very similar, just in that the way that we form study methods is very flawed. Like you mentioned before, there's a lack of long-term studies. A lot of studies that I noticed end at like 12 weeks. Well, a lot of things that happen for women happen a lot further along than 12 weeks. And so if you cut off a study, it can either make it look like your treatment worked a lot better than it did, or it can, if you cut it off at the 12 weeks, it can indicate in the study results that something didn't happen. Well, you didn't give it long enough. So, and then researchers, I'm going to call some researchers out. Some of them themselves are just as fault. The amount of published research that I've read that are referencing the Women's Health Initiative study from back in 2000, 2002, even stuff that's been published this year that's referenced it, states that systemic menopausal estrogen therapy comes with stroke and cardiovascular risk. There's nuance to that. The type of estrogen and progesterone that was used in that study was the same exact compounds as what's in birth control. Birth control has always had a warning on it that it comes with risk of stroke. Before the WHI study, we know that estrogen, I know this is a hot topic, but the bioidentical estrogen, not the compounded, which is a hot part of the topic, but the estrogen that's the same structure as what a woman makes, doesn't carry that same risk. So when you have a researcher who isn't either familiar with or taking the time to separate those two out, and they publish a paper that perpetuates this bad information, women will go to their doctor, they'll ask for solutions. The doctor says, like, I have a solution, but it comes with these risks. The woman doesn't want to take it. She continues to have her pain. We've got women suffering, postmenopausal with bladder infections, and it's killing them when all they needed was, some, vaginal estrogen, which doesn't go systemic at all. So if you're still afraid to take a systemic estrogen, a vaginal estrogen has none of those risks. And it's a potentially life-saving treatment that it's frustrating, because it's like, if you don't separate out this information, women aren't going to get the care that they need. So
yeah, I would agree. I think too that there's been some strides and movement to change things. There was just this past summer, I think I can't remember exactly the timing of it, but they had a big policy meeting just to take off the black box warning for the vaginal
Yeah.
estrogen, which got a lot of publicity. Again, I don't know what the end result, if it's changed. I haven't looked it up yet, but just the awareness of it and the fact that we're trying to talk about it a little bit more. But I would agree. I think the scientific and clinician community should really try to have some standardized language around and be very, very careful, as you said, about really separating out and dividing out, like, what is, when you're saying this, exactly what we mean. And here's the standardized definition everybody would use. I'm a big proponent of standardized data and terminology, because otherwise you're really, again, we're not having longitudinal large studies across many systems because we don't have the data to be able to do that at all right now. And so that, again, perpetuating the gaps and perpetuating the potential undertreatment of certain things or mistreatment potentially. So I would agree. I think there's void in the data and research, and hopefully more conversations like this can help move that dial. We still have generations to make up for. So
yeah. Even if we had a blank check for doing women's health research, I think right now we get to put a portion of a percent of I forget which category it is for the NIH, but women's health is even under a different category where you get a percentage of that. So even with a blank check, it's the massive amount of research we would have to do to just catch up is astounding. And then when we do have research, good research that's helpful, it takes on average, 12, 15 years for that research to even make it into the clinic setting for your doctor to even know what's happening. So I've been hoping that part of what I do is, because I'm pulling from this newly released research and getting it into the patient's hands to help educate them, I'm hoping to hurry along that cycle. It's just
agreed. The more you start to dive into it, which is kind of reason why when I started looking at like midlife women's health, I was like, what the heck? Where is it? Like, it was thankfully that we have, advocates such as yourselves and others that are open to moving this forward. And I think really trying to advocate for yourself, I think, is the other big, key takeaway that I want listeners to pay attention to. Is we've said in almost a lot of our episodes, is that finding someone that will listen to you and that honor your experiences. And if you're not finding that, it's okay to move on to another provider potentially if that's of need, but really learning how to advocate for yourself and ask for what you need.
I will give one little plug here for ISWISH is they do have a find a provider. I think NAMS also has one.
Yes, they do.
But ISWISH has a find a provider outside of the United States. ISSM, International Society for Sexual Medicine, they have a find a provider for people outside of the United States. There are ways to find providers.
Yeah, and I'll say I'll just for people who don't know what NAMS is, the North American Society of Menopause, right? North American, yeah. Or just now Menopause Society, I think is what they're going by as well. They do have on their website, find a provider. And most of them are even the Menopause Society certified practitioner, that designation as well. So you can look for those kinds of providers and I think it's by state that they go by. So that's another way to look up other researchers. So I've
even suggested to patients that in 25, 30 years old, if they're exhibiting symptoms of, I will preface that I'm obviously not diagnosing, but if their list of symptoms that they're telling me sounds like a low hormone, whether it's a low hormone or not, if they're telling me that their symptoms might be in that area, I've even suggested to these patients, listen, call your gynecologist's office and ask to see one that specifically treats menopause. Because just because you're not going through menopause doesn't mean that you don't have a hormone-related issue. It doesn't even have to be that your hormones are low. PCOS is a hormonal-related issue. Infertility can be a hormone-related issue. So if they're telling me that there's symptoms and I'm like, this kind of sounds like you're lacking, like a vaginal dryness, vaginal pain. Well, that's usually a hormone issue. Start with somebody who's familiar with the hormones. If it's not a hormone, they'll be able to say, hey, this isn't a hormone. I want you to try to see this other person. But you can ask to see these doctors. They might not all take you, but you can start asking a clinic to see you. You don't have to be 65 years old to see a menopausal gynecologist.
Right. And that's, I think, the big misconception that people are trying to overcome. I think that that's still a long ways to go, but I think it's at least starting the conversation and just asking the question, can I see someone? Yes. Whatever it is. Yes. ask, and if you don't, then go to the next person. And I know it feels like our healthcare system is not always obviously the greatest, and it can take a while to get in to see someone. So the better you start the process and the more sooner you start the process, even though it might take 3-4 months to get in to see someone, even to see your dermatologist alone for your annual skin checks can take 12 months, literally. So just starting the conversation and the process and asking your friends or other reputable resources as well, like we just mentioned, is a great way to start. Absolutely. The other question I want to ask is to dive into is medical research. And so you talked about PubMed. And I've too have gone into some of these databases, and you start and you're like, okay, I'm going in. I'll be gone for a few hours, because it can be very, as you said, you kind of go down a rabbit hole very, very quickly. It's interesting. But so then how do you approach diving into the medical research, and what have you learned about kind of why and the how behind the scenes to some of them, these health related concerns?
I will go to PubMed. Sometimes I go straight to an internet browser, just Google or something else, and I'll just type in a keyword search, but I'll put, like PubMed after it to make sure that I filter out the magazine type results. But I'll go to PubMed, type in either a symptom or a body part with the symptom or just some keywords, and it starts pulling up papers. I'll look for one that might look like it's what I'm looking for. And then you can, like on the sidebar, it'll say things like cited by, which is other papers that have used that paper. It'll have similar articles. And so it'll give you things that are very similar. I'll print off a few. I grab my highlighters, I put on instrumental study music and grab my little drink, and I just start reading and highlighting. And then it's so cool because I'll read the papers and you get little bits of information from here and there. And then all of a sudden, the coolest thing happens is you go, wait a minute, that thing over there just connected to that thing over there in like 3 papers ago. And it's just like this thing goes click, and it's just the coolest thing. So I kind of like the rabbit holes. So the why and the how I feel like are condition specific, but there can be some generalities. Most of them come down to, when it comes to like vulvovaginal women health issue, it comes down to a dysregulated hormone system. And then tied for second and third is inflammation and pelvic floor issues. You could give me any women's health symptom, and I can tie it to those 3 things. Yeah, it shouldn't be surprising that it comes down to those 3 things, because obviously our hormones play a big role. But like any symptom, I can tie it to it's a condition that might be related to one of those 3 things. And it's simple but complicated.
Exactly. And I think any of those 3 things could be a show in and of itself, just because they're so detailed and you can go so far into the research. And I think even just pelvic floor issues, I think that is such a topic that is so under addressed in women I think we need to do a show just on that, because yes, because it's so misunderstood, I guess I would say as well. And there's a lot of things that women could be doing. I think but yeah, it's not, I would agree completely. And I like you talked about the studies. I too am still a highlighter. I still sometimes print out an article. If it's a good one, I like to print it, because then I can really be very detailed and I make notes in the margin. But I look at the additional references in those articles as well. As you said, on PubMed, it'll say on the sidebar, it'll give you additional related articles or cited by. And I love going through the reference list, because it can give you even more insights to what papers that paper cited. And it truly can be a rabbit hole, but I would agree. It's a kind of those quick tidbits of ways of getting your arms around a lot of information very, very quickly. And I think that the way that PubMed and some of these other databases are set up now really are conducive to feeding you more information that's much easier to get than in the past.
Yeah. It's like their search algorithm is just, it's getting better. Yeah. The references on the bottom too are just, sometimes they're pages long, and I'm like,
yes, I know. They're great. And you had mentioned PubMed, but also I've had some good luck with Google Scholar. I use that quite a bit as well, just because it's sometimes different, but it can give you you kind of get some wild results. But it's another quick way to kind of dive in and look at some other literature as well. But I think that's but I think it pulls from all the public resources such as PubMed. But
sure, but maybe the top results are a little bit different. Like your top results are in order. Yeah.
Well, that's good. It's great advice. So what gaps still exist in diagnosing and treating vulvovaginal and sexual health problems? And really, where is this research being headed now from your perspective?
The biggest gap I have been seeing in diagnosing and treating, besides the lack of research, I mean, that that might be helpful, is the lack of what research has discovered getting into clinical practice and health sciences curriculum. That's my personal opinion of where the gaps still are. Women are commonly, we still think that the gyno is this know-all for women's health issues. And the reality is they themselves will tell you when you ask is that they're like, I've had a few hours of menopausal training, or I've only had 4 hours of sexual health training in my entire medical career and residency. We are woefully underprepared. So unless you as a clinician chase down that additional education, it's just not making it into the hands. So, but this gap isn't new. It's decades old. The curriculum hasn't changed to reflect the needs of the patient or the clinician. Med students, I am in a really cool med student research group as kind of like, I wouldn't say an advisor, maybe an advisor, I don't know. But there's med student groups out there that are forming their own sex med education groups because they are so frustrated with the lack of this education that they're developing their own curriculum to teach each other. They get together once a month. It just boggles my mind that med students and other health career students have to do this themselves despite this massive gap in what patients need and what clinicians are being taught. And it kind of reminds me of the original group of women who got together and would educate each other and wrote a book called Our Body, Ourselves. This was back in the 50s. Nothing's changed. We can't update medical curriculum to, I get that not every med student wants to go into sexual medicine or women's health. That's fine. Health sciences have clinical tracks now. You can choose which track you want to go into. The gynecologist track, in my opinion, should have how to recognize and treat women's health issues that are more than delivering babies and prescribing birth control. And I know that's an exaggeration of what they can do. I know they also perform surgery and they do other things, but there's a huge gap. There's gaps specifically for vulvovaginal health because that's very individualized. You have to perform very, very detailed patient histories because what will cause one woman to feel burning, even though you could have 5 women who have burning of their genitals, they could have 5 different diagnoses. And so it's so individualized. And I know that's not helpful, but that's part of why there is a gap is because you have to dig. You have to get so granular of what their history, what their medical history is, what their hygiene history is, what their day-to-day history is, because somewhere in there is the solution to what is happening. And we just aren't digging far enough into these histories. We're giving a general wear cotton underwear, make sure you pee after sex. Okay, there's women that are doing all of the things. It's time to dig deeper. So,
yeah. And I think too, medicine got or healthcare, we're really good at about putting people into these boxes or buckets. And this is the pathway. This is your clinical track. This is what you'll be getting. This is your prescription. This is the treatment plan, that kind of thing. And so but we're realizing that that's not the way to be. And that's why we need to be getting back to, like you said, that more individualized, very deep. But also we just, unfortunately, and I'm not making excuses for providers, but they're feeling the pressure. They get 15 minutes. You get 15 minutes with your provider. And so you better come in with your list and the top 1 or 2 things because that's all they can address. And that's so unfortunate, but yet you have to be very efficient about what you're coming in for. And it may take a few visits, which is super frustrating for the patient because I don't have time to keep going to the doctor. But at the same time, there's always this push-pull. So I would, not to get off topic as well, because I think it's definitely pointing back to the gaps and where we need the research. And I think it's getting it into the hands of clinicians and patients sooner is part of that cycle that we have to really start to try to circumvent on much more quicker basis, I would say.
Mm-hmm.
Yeah.
There are some patient advocates that have been trying to develop, I'm blanking on what it's called now, but it's where you come up with a type of questionnaire, a validated questionnaire or exam. We're trying to develop some better questionnaires and exam procedures that clinicians can start implementing to cut down on the time that's needed, but also glean what they need. So I know that things can be very detailed, but there's some tricks and tips that the patients know of that we're trying to get into the hands of clinicians in a validated way so that they realize that it's something that they can perform and be able to prescribe off of. So I know that they have to be cognizant of that too.
Yeah. And that's a perfect example of, I think, working in partnership. Like, as the patient, I know what I need to be asked and what I, help that provider drill down as quickly as possible in that 12 or 15 minutes that we have to get to the root of the cause. And so that's I think, another great example of how we can hopefully better partner with healthcare to come up with the solutions that we need, which will hopefully then cut down on that cycle of actually implementing it within 17 years or whatever it is. Yeah. Yep.
I do know that menopausal gynecologists typically get a little bit longer. Sex med specialists typically get a little bit longer. I would say on average, a sex med specialist gets about an hour with you, and it is usually covered by insurance. I think because they fall under like that specialist area.
Sure.
And so
Yep.
you kind of get more time. So that's been helpful for patients. But yeah, that initial visit where you're like, well, I have to get a referral. So I have to go to my GP and they only get 15 minutes and they don't know what to do. And so it's a frustrating. I think we figured out that women spend on average, 5 years and 10 doctors before we get to the doctor that figures it out.
Yeah. And that's across the board for many conditions of what I've been kind of even realizing. It's so unfortunate. And so again, I'm really hoping that people can take a role of being an advocate in their health. And so I think you're a great example of being that, and what you've been able to do is pretty awesome. So love that. Yeah. And so my other question is so those that want to get more involved in potentially, societies and other advocacy roles. So how does your work with ISWISH support patients and also professionals in this space? And you've mentioned curriculum, which we'll come back to as well. I think that's another key component, I think, to be including in some of your advocacy work. So it'd be great to hear more about that.
So most of what is presented at the conference that I go to for ISWISH, I can either choose to sit in and listen or read later once it's published after the conference. It is nice to sit in because you can ask questions on the spot. I am usually right in that line to ask a question because I'm like, what about this? What about, you didn't think about this? Did you consider this? Like, did you even ask a patient if this was help? So I'm nice about it, but I'm like, what about all these things? I get one question because there's a line behind me and I want to know what you did. The conference itself is a great place for me to develop a relationship with the other people that are going. They're clinicians from all types of tracks. There's pelvic floor people, there's urologists, there's GPs, gynecologists, people from all over the place. There's tons of researchers. So I'm developing these relationships with these people who are trying to do something about the gaps in their research and care. And then we can have this back and forth conversation about, I heard what you were doing. I didn't get a chance to talk to you. Can we have, a few minutes to talk? What are you doing here? Did you consider these things? Can we have some back and forth? Here are some projects I've been thinking about, working on. Are there things you want to start working on that maybe I can help patient populations for? And then, that's me giving them some assistance, kind of giving them like a boots on the ground patient perspective, right? Like, here's what we need. Here's some projects you can maybe look into, some perspectives. But then I can also go back into the real world after the conference. And I have clinicians I've developed relationships with that I can recommend to people that I'm helping online or to patients that I talk to. And I can say, this clinician, I know them. I've seen what they've been doing. If you can get there, that's been very helpful because sometimes when you look at these provider lists, you're like, while the lists aren't necessarily extensive, they're like, I don't know who to choose. I am sick of spending money. I'm tapped out. Who do I go to? And sometimes they're afraid to see a male provider, and I can't convince anybody to change their mind on that, but I can provide them info like, hey, like, this person is very passionate about helping women. If that's the only one that you can get to, they're going to help you if you can get past them being a male provider. And I understand why women are sometimes reluctant to see them, but some of these men that are in this women's sexual health research spaces, they're just like, I'm just trying to help you guys, and I'm doing the best I can. And I just got my practice, and I get the reluctance, but I'm trying to help. So that's kind of the work I've been doing with this back and forth in this space, doing projects,
I think insight for someone who's wanting to get in there and help and wanting to learn themselves. And how do you start to partner with providers where it seems very non-approachable potentially at times because
Mm.
you're the patient, they're the provider, and there's sometimes can be feeling like there's might be a hierarchy. But I mean, as a researcher too myself, I want to hear from patients. I want to hear from participants. It will make our end product that much better. I think if I can get that insight on the upfront as well, and really then continue to partner along the way. And I would say conferences are a great way to make those connections. It may not be in the short term, but you might be knowing someone that you think, oh my gosh, I met this person last year. I think that they were doing XYZ. I'm going to reach out to them now because now maybe you have the time and the resources, or something else sparked your memory. And so it feels like it can take a while, but those relationships can be long term, really. I think it's
And
a good way.
unfortunately, a conference, like I can't even really think of, I know that conferences sometimes cost a lot of money.
Yeah.
And I'm paying for everything that I do to help patients out of pocket. And I do it willingly, but not everybody can afford to go to the conference. And I understand that. And so it's like, where do you find a space where you can connect with researchers or clinicians who want to partner with a patient perspective? And besides online, and then are you sure you're getting the person that you think you're talking to? So it's like, I get it's hard to connect. It's not that third space.
Exactly. The other thing I would think of is too, some maybe on a smaller scale or some other health systems or smaller clinics, I would say, and some larger health systems, they're starting to have more patient advisory boards,
Oh,
which, for like a broadly across the health system potentially, but yet that's one way to start meeting clinicians in your specific specialty potentially. I think like Children's of Minnesota, I think they have a patient advisory board. And so I think that more are starting to have those roles. I don't know exactly who to connect, but I mean, you can even just ask your provider within that health system to say, hey, do you know if there's a patient advisory board? And other smaller clinics have some of those as well. I think it's easy. I'm thinking of it just because with the Fairview Health System where we are, it's because it's an academic partner. It's tied with the university. So there's maybe potentially more options there. But I know of other institutions that are really trying to look at how do we formulate an advisory board. And then once you're on the advisory board, what's the role and what do we do? Still being fleshed out, I think, across the board. But I think it's a start, entry point, at least for people if they're looking for that kind of feedback and input, for sure. So I guess my other question too is, listening to many women who may experience some of these issues, what's the first step that you would recommend for them to take to advocate for their own health?
that one, first step, start journaling. Seriously. So we mentioned earlier about some of the things that I've been working on. One of the things is a symptom tracking spreadsheet that I'm working on. Those kinds where you can just like have drop downs and inputs and it does all the calculations for you. Like I'm working on like a big fancy spreadsheet. But in the meantime, before I get that out, start journaling. One of the most common things that I see and hear about, and even my own experience when I was seeing all these doctors for 10, 12 years I was dealing with, is if I would either forget something or I would forget how frequent, or I would say it's all the time. All the time isn't helpful. How many times is this happening? If you start journaling, you're going to see patterns. Maybe you're only having burning, or I don't know how squeamish your viewers are, but if you're having a yeast infection, is it the same exact time every month? That's going to tell your clinician to look at what's happening during that month. Is your estrogen high? Is it in the toilet? Are you doing specific things? Are you engaging in certain activities? Not that it's ever your fault, but if there's certain things, like I go swimming every 2 weeks, guess what I'm getting every 2 weeks? I'm getting either dermatitis or this infection. Well, that might not be your fault, but at the same time, it's the pattern, it's the cause. So if you're journaling, you're figuring out just how often it's happening. Are there other things that are going on? What's the intensity? So these things can be very, very helpful for the clinician that you're seeing. It cuts down sometimes on the time it takes to go through the history. Sometimes your history doesn't follow you from one system to the other. If you see one person at your main clinic and you got to see a specialist who's not in there, well, now you either have to request your records, which takes 2 weeks to get there, or you forget it half the time. Sometimes things, for example, like these hot flashes from people in midlife and perimenopause, they're not always sweating. And these great dramatic hot flash, mine, where I would wake up in the middle of the night and I'm like, I'm hot, get the blanket off of me. And I go back to sleep. But it would happen like 2 weeks every month. And it was happening every month, but for like 2 weeks. I called my specialist and I said, I think I'm having hot flashes because the temperature hasn't changed, my blanket hasn't changed, but I'm getting hot for like 2 weeks. She goes, it's probably your hot flashes. I'm like, but I'm not sweaty. She goes, doesn't have to be. But because I was already in the mindset I know that everybody has my mindset, but I'm in the mindset of following and tracking and noticing patterns. I think you're having hot flashes. Okay. That was resolved quickly because I was inside my head, I suppose, journaling, but tracking.
Yep. That's a really, really, I think that's great advice because it is true. And I think too that when you think of specifically, I'm just thinking of hot flashes, like I was envisioning like you had to be like pouring with sweat and like just some people are absolutely. And I think, but there's these nuances within that as well. Like you said, you wake up and you're like, this is weird. I'm hot. Like this is not normal. And also and I think you can easily brush it off. But I think too, if you're journaling and you're being more cognizant of it, you're starting to see like, oh, this happens at this time. Or I'm getting potentially a yeast infection or a bladder infection or whatever it might be. I think it's just bringing more awareness. And I think going into your provider with that insight is so helpful on the upfront because it's like you said, it's cutting down on the time that they have to ask the questions, digging into your history. You're the one coming in and saying, look, I've had 10 hot flashes in the last 3 weeks or whatever it is, I'm making it up. But that's such great advice. And it's something concrete that you can track yourself and that you can come in then when present kind of with, not that you have to have rationale, but you're coming in with some solid evidence to say, like you said, it's not just a blanket statement. This always happens to me, or like, oh, it's only happening once. Actually, it's quite a bit. And you're, just now that you have a data to show it to your provider. Yeah. I love that. Yeah. So everybody start journaling. I love it. So kind of closing out here as well. So what is one piece of advice that you would give women in their 40s and 50s to really prepare for a vibrant and empowered life?
This one was harder for me to decide. And I had many, many things, but I chose lifting weights. I would really like to say to have systemic estrogen. That's a little beyond patient's control, but lifting weights, it will strengthen and promote bone growth to prevent osteoporosis and fractures. It will keep your cardiovascular system healthy. It stimulates testosterone production. And for people who aren't aware, our estrogen is made from the testosterone, the pre-testosterone, the androgen. So like you're boosting your testosterone for sure. There's a small boost in the follow-up estrogen. So you're getting those stimulated. You're keeping yourself moving. It's great for your brain and your cognition. If you are keeping your testosterone levels up a little bit, you're also feeling, hopefully feeling the desire to be intimate with your partner, which goes a long way in your mental health and your relationship. So yeah, it's keeping your body healthy. It's keeping your mind healthy. So yeah, even if you don't want to take hormone therapy afterwards, just lifting. It's also when you lift, I don't know if you lift or you know what he does, but when I'm at the gym lifting, that's a cardio workout. My heartbeat is going like crazy for 30 minutes. And you don't have to have a gym membership. You can jump up and down a stair for a minute, and that provides some stimulation to the bones. You can have resistance bands at home and be doing resistant band exercises while you're watching your favorite show, hanging out with your partner who's on the couch. Just get some resistance bands. Make your body move with something that provides resistance.
I love that because I would kind of ebb and flow with my lifting schedule, but it's a different feel after I lift versus after I go for a run. So I'm a huge proponent of lifting, especially now with all the research coming out around brain health, cognitive, moving as medicine, all of those things, bone health, mobility, and I'm a huge advocate in saying it, my mantra is that I think midlife is such a critical window for healthy aging and staying independent. That's our goal is we want to stay out of the nursing home, and we have to be incorporating it. So I like you said, you're incorporating it into resistance band, watching your favorite show, grab a buddy, both of you have dumbbells. You don't have to you can do it over Zoom if you wanted to together, but
it's some way. It doesn't have to be in like an hour or hour and a half, like some of these people do. People who are doing it that long, that's their jam. It's their hobby. 30 minutes a day with a resistance band and a couple of dumbbells while you're watching TV. That's all you need. And it doesn't have to be anything extravagant. It's just keeping up your strength, keeping up the strength. Your muscle mass drops so quickly after midlife.
Yes. And I'd love to do it. Like you said, that's another idea for a show is literally on osteoporosis, but then what happens with the loss of muscle and the loss of bone health, and then the increase of fatty tissue or sarcopenia. And that combination, I think, is so detrimental to healthy aging. Love to touch on that topic as well, but that's such great advice. Journaling and lifting weights, everybody. That's the message.
Yeah.
Well, thank you so much for your insights today. It's been such a great, I love hearing about your work. I love working with patient advocates, and I think it's such a needed in our society, specifically around women's health. So thank you so much for your time today.
Thanks for having me. It's been fun.
Great. Awesome. We'll get this posted here soon as well. So thank you. That's a wrap on this episode of Midlife Unmasked. I hope you found inspiration and a few key takeaways. If today's episode resonated with you, please be sure to share it with someone else that could also benefit. And don't forget, this podcast is here for you. If you have a topic or a question you'd like us to explore, please send it our way. Your feedback helps us reach even more listeners on this shared journey. You can find us on social media and our website, midlife-unmasked.com. That's midlife-unmasked.com, and the links are also in our show notes. Until next time, keep unmasking your potential, embracing the possibilities, and living your best midlife with courage and confidence. Take care and see you next week.